superior to 2D, and it was statistically significant. Now, you might say 90% is still pretty good with 2D, but like I said, we're not repairing all the valves we should. So any incremental improvement we can make in diagnosing what's wrong with the mitral valve could be of very significant importance. This study, just to summarize then, was the first real-time 3D TE study showing superiority compared to 2D echo in the operating room in a prospective group of patients, especially beneficial for these particular regions of the mitral valve, and it shows great promise in mitral valve pathology. Now here's just some examples from the study just to see the diagnosis of a flail posterior leaflet can be made by 2D echo, but look how much better we can delineate the actual leaflet pathology by 3D. We can see the area of the leaflet prolapsing. We can see that there are multiple torn chordae. And we get real-time moving pictures as well as the still frames. The diagnosis can be made rapidly. This is a straightforward mitral valve repair. This is a surgeon of not great clinical skill can repair this valve, would not need to be referred to a center of excellence. Here's a more complicated mitral valve repair. Indeed, by the 2D echo, we can see that it is a flail middle scallop of the anterior leaflet. But only by the 3D technique can we also see that the anterior lateral scallop, or A1, is also unsupported. Surgical repair would involve not only fixing the middle scallop of the anterior leaflet and 2 torn chordae, but it would also involve probably some extra neochordae to help support the anterior lateral scallop. Very important difference that really wasn't well seen by the 2D echo. And finally, Barlow's disease. This is a very difficult mitral valve repair. It takes great surgical skill to get a long-term, sustained, good result. You must make the diagnosis, and if you have this diagnosis, make sure your surgeon has excellent skill. This is indeed bileaflet prolapse, a very myxomatous valve. But by the 3D technique, you can tell the surgeon exactly where the areas are billowing the most. What are the areas that he needs to really work on in the valve repair? And going into the surgery ahead of time, he will have a game plan as to what to do to repair that valve. You can make that diagnosis by 2D, but it takes a higher level of skill than it does by just looking at the valve in the en-face view by 3D TE. Now, one final case, interaction with the audience. Nobody answered my last question, but let's take a vote. You only have 2 choices here. What's wrong with this mitral valve? This is a 60-degree commissural view of the mitral valve. We can see an abnormality here of the lateral area of the mitral valve. Is this a problem with the anterior leaflet, A1? Who says that? Any takers? Who says the posterior leaflet, P1? Once again, no enthusiastic answering of the questions, but that's okay. The point will be made here that you can't tell for sure unless you have the probe in your hand, because slight anteroflexion will allow you to look at the anterior leaflet in that view. Slight posteroflexion will allow you to look at the posterior leaflet, plus going in and out just slightly can change which leaflet you're looking at. So it's very complex to make that diagnosis by 2D echo. But by 3D, it's real easy. We know that this is the anterior leaflet up here, and sure enough, we can see some damage here. This is a patient with previous endocarditis. It's flail. You might call it a slight perforation, especially on the still frame. It does involve a commissure, but the surgeon will know exactly what to address when he goes in there for the operation. And this valve is definitely repairable, easily repairable. When you show the surgeon this picture, he'll know exactly what to do when he gets in there. There won't be any surprises, and the patient can expect to have a good result even before they might be symptomatic. So in conclusion, 3D TE for the mitral valve is still in evolution, but it can complement current echo techniques. It's not to be used in isolation, but in conjunction with the 2D echo. It provides a better understanding of the tomographic aspects of pathology. It defines the spatial relationships, allows you to look at the valve en face from both the left atrial perspective as well as the left ventricular perspective. It's accurate, it's reproducible, and it's not time exhaustive. Better understanding of the mechanisms is very important. And increased diagnostic confidence, and that's the way to improve our success rate with mitral valve repair. Thank you very, very much for your time. This is my final presentation, so I once again would like to thank you very much to the organizing committee for allowing me to share some data. Thank you.